Many questions, but the one that occurs to me is the most simple and logical is anybody going to sort out which of all these hormonal agents is better than the other one? Or are we going to end up with 3 or 4 that have to be used in combination? I guess there is a rationale for using an androgen receptor antagonist with something that decreases the production of the hormone. But one thing that occurs to me, Mary Ellen, maybe you can answer this question, is are people actually going to compare the two in the same situation, or to compare the 3 active agents that we now have?
Yeah. One of the important questions is when somebody's failing one, say they're on abiraterone and they're progressing, do you stop the abiraterone and go on to a sequential one, or do you continue the abiraterone and layer on? So there are trials that are looking at that question, large trials that are powered to answer the question.
In the patient who's just failed castration or chemical castration, we have a choice of several drugs that could be used in that situation. Do we know which one works best as the first agent?
We do not, and I'm not aware of a trial that's
I
primed at
imagine
this
the
point
companies are reluctant to do that because they all want to remain on the market. They don't want to lose whatever position they have. But it seems to me an important question to answer.
Yeah, we're at risk of ending up like kidney cancer with, 4 or 5 new agents, and you're not really sure which one to use first or how to combine them.
The early experience is that there does appear to be a substantial amount of cross resistance, and you saw that in one of the waterfall plots. For example, the response rate of, for example, enzalutamide after abiraterone is relatively low, substantially lower than enzalutamide up front, and the converse also appears to be true. That's early data, but it seems to be a fairly consistent observation. So if correct, would predict that there may not be a lot of additional gain. Doesn't mean an individual patient won't benefit. So if you accept that, the scale of trials to look at questions like optimal sequences versus combinations would be massive, and I'm not sure that the community has the appetite to do the correct trial to inform clinical management. There will be trials looking at combinations, but they don't necessarily answer all of the relevant clinical questions.
I'd like to also comment that we faced this very question. We were trying to study this androgen receptor signaling within CTCs, and we had this idea that we may be able to identify those men who will or will not respond to something like abiraterone, and so we wondered whether or not any company would put themselves up to sponsor a trial that would potentially cut back on the number of patients that might get the drug. And but we actually received support from Janssen to do this study, to do the abiraterone study, to look at the AR signaling prior to treatment to see if we can identify signatures of these AR signals that may predict response to or lack thereof to the drug. So they're not all looking to make certain that everyone gets the drug, but it was a challenge.
Some of the markers that we have available for stem cell biology have very similar character to what I've heard at this meeting about PSA. And it's that historically when you had a biomarker that it was the only thing that was available, even when some better things may be coming along or when you discover that it's not very good, there are lots of reasons why it's tough to stop using it. So my question is, although it's clear now that PSA is not ideal from what I've heard in my days even my days in medical school many years ago, is it causing problems using it? The question is, would the studies be better off if it wasn't being used as a stratification basis?
I think Matthew should comment about the Aragon trial.
Well, sure. There's it's very challenging, and it's ingrained basically in the medical culture, patient understanding of the disease. So, but we do have to separate the issues we're talking about. So PSA for use as a screening test has major, well-described limitations. As a monitoring test, it may be better, but it does lead to substantial confounding in the field. So Mary Ellen nicely described the importance, and I wholeheartedly agree with this statement, that we need intermediate endpoints. We can't do every trial based on overall survival. But in prostate cancer, we have this distinct problem that the prevalent use of PSA testing leads to biases of other testing, imaging, frequency, physician assessment of an attribution of events, whether it be due to disease or otherwise. So it is a potentially huge confounder. And so in the Aragon trial, the Spartan trial, we're using PSA as a marker of high risk for progression, but we're actually proscribing the measurement of PSA during the trial because, in fact, it shouldn't be informing clinical management. It would be the onset of detectable metastatic disease that would need the next intervention. But that's going to be very challenging to get patient and physician buy-in to do that because of a long-standing tradition of measuring PSA frequently in recurrent disease.
On the topic of diagnostics, I just had actually a question for Dr. Garraway. So since we've all agreed that we need other ways of assessing prostate cancer, other means of biopsy, liquid biopsy such as CTCs, ways of predicting responses. So you've identified a phenomenon that's, I think, new to most of us regarding the existence of these chains, perhaps in the majority of prostate cancer. Is that something that might have diagnostic utility in some way?
So I think the short answer is that we would first need to do a study that allows us to detect this prevalent, across a large cohort and ask whether or not the presence or prevalence of this event correlates with aggressive disease, which it might, but that would have to be done. I think in theory, this is the kind of thing that, if that were true, could have diagnostic utility, except that right now, there's no way to find it except by sequencing the genome, which I think is not really a valid proposition in any clinical scenario right now, much less the sort of early diagnosis scenario. So if there was a way that we could figure out to, like perhaps a surrogate marker for this event, maybe there would be some, if we can understand why it happens, maybe there's some DNA repair-like marker that would tell us that this thing is more likely to occur that we could use as a surrogate, then I think there might be something to discuss. But right now, I think it's just not something we can move to the clinic in a realistic scenario that I can think of.
So Rick, in the CTCs, you're looking at single gene rearrangements. Is there any possibility of scaling that up to fuse what you and Dr. Garraway are talking about in some way? I realize we can't take every cell and do a whole gene sequence, but somehow improve the diagnostics and get us to a point where we have really powerful surrogates from CTCs.
No, I think what we've seen so far with the single cell picking from the CTCs and the patients with castration-resistant disease is that the gene expression profile is very heterogeneous. So I'm not certain that any one selected cell will accurately portray everything that's happening within that patient. But that's what we hope may be the promise, is that if we can identify the representative clone, if there is a dominant clone, then perhaps there is a way for us to marry these two technologies together.
Dror, is there a opportunity here also to ask a sort of a practical practice of oncology question? And that is, as this surplus of riches that now we're the beneficiaries of, and as you are developing them for prostate cancer are abounding, the practicing oncologist, are they going to have to, or the urologist as well, change their practice to, as they use these investigational drugs that are now being newly approved, that they've got to monitor their patients more acutely, more carefully, to pick up resistance so that they can go on then to perhaps a second or third line more effectively? The question that I guess I'm posing is that if this is not monitored, these patients are not monitored carefully, might we not foreclose some options of actual recovery for some patients? Rick, that's your question.
Well, yeah. Personally, I think that, you know, with the advent of all these newer oral hormonal agents, it has been easier for patients to remain in the care of, say, the urologist or the treating radiation oncologist. And we, as medical oncologists, are getting patients who are a bit further along in their treatment course, and that's when they get referred to us for things like chemotherapy and the like. I do think that those patients who have recurrent disease and castration-resistant disease should be referred to a medical oncologist as a standard practice, and that we should be the ones managing the care of those patients.
The concern that sometimes has been expressed to me is that if patients just go on, let's say, abiraterone right away, early on as first line, and stay on this orally administered drug for a long time, by the time they may actually relapse significantly, they may have foreclosed options of some secondary line, even cabazitaxel as an example.
Yeah, so, sorry, go ahead, Matthew.
Matt,
I
did you?
mean, I think that's a fair concern. I think the bigger concern really is that to the uninitiated, there'll actually be premature discontinuation of therapy. So in the studies that demonstrated benefit of abiraterone and enzalutamide, treatment was continued beyond PSA progression, and typically in some of the trials even beyond radiographic progression, really till symptomatic progression. So I think the bigger picture concern is I worry in the community there'll be some premature discontinuation, you know, patients who have an excellent response discontinuing for a modest PSA elevation, which I think probably do be a bad decision for the patient. The other issue is that these drugs are comparatively safe and well tolerated to chemotherapy, but still do require some monitoring, and the necessary tools and interest to do that may or may not be within the bandwidth of the treating physician, some of the treating physicians in the communities, particularly urologists, who may not be all that interested in monitoring things like blood pressure and serum potassium and other issues related to these medications.
Yeah, and Marty, one other thing here, and I think with this I want to take it back to Mary Ellen for a moment. I worry a little bit about the notion that we have an embarrassment of riches, that concept. I don't think we do. I think once we have curative therapy, that might be the case. But when these drugs are given in advanced disease, we're still looking at timelines that are measured in months to a year or two for each of them. And we're also seeing that there's cross-resistance between some of these most exciting agents. And so to go back to Dr. Taplin's talk, what would really be ideal is if we found a way to incorporate these agents and hopefully new ones in the future into curative models. And probably that means treating earlier disease. And one of the challenges, of course, of that will be, as a number of you have alluded to, how do we do those trials in a way that's time efficient? Because for better or for worse, the survival is typically measured in many years. And so if you do a phase 3 trial in early disease, you have to be willing to wait 10 years until you have a survival benefit. So to the whole panel, I would say, if we want to look at curative therapies in early disease, what are the valid endpoints? What are the legitimate endpoints we can use in a trial? Is it path CR? Is it circulating tumor cells? What is it that we would advise regulatory agencies in terms of what we can measure in early disease to help move these things forward faster?
Well, there's a big initiative that is being run by Chris Sweeney in our group and Phil Kantoff with PCF and I think some partners in industry to do a very large meta-analysis of all the adjuvant and neoadjuvant trials that have been done in conjunction with surgery and radiation, and to gather that data, to look at endpoints in those trials, and then to present it to the FDA to try to get buy-in from them to look at surrogate endpoints, some of the ones that you've described, but pathologic endpoints as well as freedom from PSA failure, freedom from metastasis development, and things like that. So I think the answer's out. I think there's a lot of, belief on this side of the panel, the white coat, the prostate cancer doctors, that it's long overdue. So I think there's some momentum and some money behind and effort with a lot of partners to try to move the field in that forward.
So Matthew, maybe you could comment, because I know certainly in the ARN 509 trial you had to think about what types of endpoints would be acceptable.
Sure, and that'll become one of the early tests. I think the FDA is willing to work with investigators and sponsors to use intermediate endpoints, and I'm deliberately choosing the word intermediate, not surrogate, because you're not a surrogate until you establish surrogacy. But for example, the primary endpoint of that trial will be metastasis-free survival. But those will all be review issues. I mean, there's no established surrogate outcome in prostate cancer for survival to date. There's some promising leads, and Mary Ellen mentioned some of those, and some important efforts to look in the future. But we can make recommendations, and key opinion leaders, experts in the field have opinions about these things, but that's very different than regulatory acceptance. So all these will be review issues, and the challenge for sponsors is that these are, $100+ million bets on trials with FDA position is that will be a review issue. Very difficult place to be.
Man, I couldn't let you stop without answering, or at least trying to answer a question I've asked you at least a dozen times before, and that is, how do you explain PSA progression and at the same time patients are responding in terms of bone lesions getting smaller and even soft tissue lesions getting smaller?
In the case of cabozantinib?
Yes, I think that you're going to defeat the effort to define intermediate endpoints with that one trial.
I'm not sure if I understood the latter point, but the actually, to speak to your point, though, that trial we have embedded a novel endpoint, which is bone scan response using an FDA-cleared methodology, with the hope that you would then be able to, if a positive trial for overall survival, you'd be able to look at the relationship between an intermediate endpoint and survival, and potentially use that for guidance in future trials. But in the case of cabozantinib, it's relatively straightforward. Some of the known targets of cabozantinib do impact through feedback AR signaling and PSA expression. So it's quite reasonable that, and there's other data from other model systems, other TKIs, that the same is true. But I'm not concerned about that partial discordance of PSA and anti-tumor activity for the following reasons. First, there's not complete discordance. Some patients do have PSA declines, and all of those basically respond. And the CTC data, which is a sort of independent way of looking at anti-tumor effect, also shows responses. But ultimately, to answer your question, we'll have to await the results of the phase 3 trial. So you'll only have to ask that maybe half a dozen more times, and in 2014 we should know.
It would be really nice if we understood that there were multiple populations of tumors, and some of them have differential control of androgen response. In other words, are there mutations in the androgen receptor that would explain it, or other factors?
I wish we had a more thorough preclinical understanding of the drug, although I have to say there's a couple recent publications, one in PLOS, that look at this issue, and in preclinical models with that drug cabozantinib, there's very clear impact on tumor, on bone, and tumor-bone interaction. So just sort of as predicted from that cartoon that I represented, there's now experimental evidence for that in animals.
Maybe Levi can answer to that.
Yeah, I was just going to make a general comment. So certainly this is going to be true in prostate cancer resistance, but this has been true in resistance to a variety of targeted agents, that I think we are vastly undersampling the extent of heterogeneity of resistance mechanisms. So what tends to happen, just an example, in melanoma that becomes resistant to RAF inhibitors, you can sequence either an exome or a panel of genes, and you come across the mechanism you recognize, and you go, aha, this is it. But in fact, if you look deeper, you can find sometimes there are multiple of those mechanisms, even in the same tumor focus, to say nothing about different METs from the same patient. So, and I think this is likely to be true in prostate cancer as well, and we also know that there are both genetic and non-genetic mechanisms by which resistance can rise. So I think resistance heterogeneity is a huge issue, and so it's not surprising at all that you could see a patient responding but yet still see a PSA rising, because all you need is one or two foci that aren't responding as well, and you'll see PSA going up. So I think we're going to have to come up with a framework of grappling with that heterogeneity at some point.
All right. Thank you all very much.
Stay right there. Why doesn't the panel stay and also Dror to just make a comment, and then Bruce is going to close the Chabner colloquium. Yeah, you just are. But before we do, you know, Dror, your opening slides in which you showed the previous parts 1 through 3 of prostate cancer progress and promise, one anecdote was that the first one, part 1, occurred 32 hours after the FDA approved abiraterone. That was just by happenstance. So that part 1 of this series actually started at the time when that drug was FDA approved, and already now its primary supremacy is being perhaps shunted aside into a secondary line of treatment. And I stand corrected that there is not a surplus of riches, but there's I don't want to say a surplus of assets, but there certainly are increasing assets, and it's panels such as this that you put together, Dror, really that is going to be so helpful to a viewing audience of tens of thousands, most often of practicing oncologists and many increasingly urologists who are looking to these prostate cancer progress and promise programs to see where we are and where they ought to be going. So on their behalf, let me thank you, Dror, and the panelists for another very enlightening program. Thanks again. And now over to the Chabner of the Chabner colloquium.
Well, very brief remarks, just to thank everybody for participating and just say that I think after being here for 2 days, one can only conclude that in order to deal with this disease, we need people that are working both at the very clinical forefront and at the basic science front, and those in between. And there have been some marvelous presentations here of brilliant work on all those fronts. And I can only leave with a sense of optimism that we've really learned so much about cancer, and it has to change the way we treat it and the way we survive the disease in the next few years. And just thank everybody for participating.